No, it's okay. I've just started the recording, that's all. We're not starting yet. Hi, everyone. We'll start in just about 5 minutes.
Sounds good.
Even if we're member people involved with patients, but it's still serving, not like that. Not like short review or whatever. It's just like a they send surveys to them saying like, or they send surveys to program directors.
Here we go. Let's see. And you show and everybody else. Okay. Let's see. Dr. Yellowlees? I'm just checking audio. We're fine. Just checking audio. Oh, checking your audio. Bear with me one moment. What number are you calling in on? Can you type it in the chat for me, Dr. Yellowlees or Dr. Rea? We're going to start in 1 minute. Great, thank you. Dr. Yellowlees and Dr. Rea. Just checking audio. Oh, okay, bear with me, didn't get the right number. Okay, Dr. Yellowlees and Dr. Rea.
Yes, good morning.
There we go. Okay, bear with me just a moment. We'll start in about 15 seconds.
Okay. "31 people now. I recognize anyone."
Good morning, everyone. We will go ahead and get started now. So thank you so much, first of all, for attending. Thank you for joining us. We have wonderful speakers. We have two speakers from UC Davis Medical Center, and we have a very important and, of course, enlightening topic for our webinar today. So we'll get started in just a moment after I go over a couple of logistical items. This webinar is being recorded. There is, of course, a slide presentation. Everyone should be able to see the welcome slide for the Stigma-Free UC deck on your screen now. And if not, please use the URL that's posted on UCNet under News or via the link from the UCNet main page. All the lines have been muted, and also all video will be turned off. I will go ahead and catch those video windows that pop open in case you miss it. But if you could be proactive and ensure that you are not broadcasting video during the presentation, that would be appreciated. By simply mousing over, moving your cursor over the toolbar, you can stop video via the stop video icon. We do, of course, want to hear from attendees, and so we'd ask that you please use the Zoom chat feature to submit your questions. The chat icon will appear if you hover your mouse along the bottom of the Zoom application window. You get a toolbar, and you would click on the word that says chat with the under the more menu, and if you click on chat, the chat dialog box will open. You simply type your question in the field, and then you hit enter to send it. Generally, we will field questions at the end of the presentation. We'll leave plenty of time for question and answer, but if there happens to be a particular question or concern that seems relevant to the slide that's being discussed, I will go ahead and I will gently interrupt our presenters and ask that they field a particular question. But in general, we'll wait till the end for any questions. Now, as I mentioned, this webinar is being recorded, and the recording link will be available by Monday, the 5th, and it will be on the UC Living Well page on UCNet. Okay, now that we have our webinar house in order, I just want to explain briefly about how today's session fits into the bigger picture. The webinar was created in partnership with Peter and Margaret and the Stigma-Free UC initiative, which is part of System-Wide Wellbeing. The System-Wide Wellbeing sponsors and promotes events, programs, and resources that impact and improve UC employees' emotional, financial, physical, and nutritional well-being. And in support of UC employees' emotional well-being, the Stigma-Free UC initiative was developed to foster open, positive discussions about mental health, because the first step in reducing and eliminating prejudice regarding mind disorders is to talk about them and to promote awareness around this multifaceted topic. So to that end, the Stigma-Free UC is a one-year awareness project which provides monthly programming and is focused on the elimination of mental illness, discrimination, through educational webinars such as this, discussions, videos, and more. And because every human being lies somewhere on the mental illness continuum, the overarching goal is to increase our collective compassion by sharing the vast knowledge of UC experts who will help us learn about the spectrum of mind disorders and how to avoid ostracizing individuals who live with them. The polarizing concept of the other crazy person no longer exists. The continuum of mental health and illness encompasses all of us. Statistics show that those who learn about mind disorders show more compassion towards those with a disorder. Therefore, throughout our 2018 programs, we'll continue to emphasize that mind disorders are simply part of the human condition. And now I will introduce Dr. Yellowlees.
Well, thank you very much indeed, Maura, and thank you to all of you who are attending. We're very pleased to see so many people here. Dr. Rea and I are going to sort of do a sort of double act here. I'm going to do the first half of the presentation, and then Dr. Rea will do the second half. But I want to emphasize that we work very closely together, and we're really talking about one topic between us. So you'll find that I'll be focusing probably more on the sort of clinical aspects of physician health, and Dr. Rea is going to look at more at the preventative issues that are really important. We both work at UC Davis, and we've both been on the Medical Staff Wellbeing Committee for at least a decade. Now, all of the UC health systems have this committee, which is set up in accordance with the Joint Commission recommendations. So they're mandated to have these committees. And the aim of most committees is to improve and secure physician healthcare to ensure that our patients are looked after by physicians who are obviously unimpaired and able to do their job properly. So ultimately what we're talking about today is actually about patient safety. But clearly, if you're going to have safe patients and good clinical care, you have to have healthy, fit, effective physicians and other providers. And now we're focusing mainly on physicians today, but obviously what we're talking about relates to, in our system, quite a number of PhD providers, as well as obviously a large number of other clinicians. So I'm just going to throw this to Dr. Rea, just to so you can hear from her initially, and then we'll move on.
Yes, hi. And again, thank you for attending. Yes, I'm Dr. Yellowlees is a psychiatrist and I'm a psychologist. And so we're going to be talking about our committee, which I think fits well in the topic about the issue of stigma, because our goal is to approach our physicians, which includes our residents and fellows, and encourage them to reach out around issues regarding mental health. And physicians, as many of you probably on the call recognize, there's a very heavy layer of stigma around accessing care and discussing issues around mental health. So, many of our initiatives on the committee are to how can we reach our physicians, because when people go underground, obviously any of us with our mental health challenges, it's not a healthy or safe place for us to be. Here we have the added burden in that we have to also look out for our patient population. So our goal is to get our physicians the care they need.
Okay, well, thank you. And if we could move on to the next slide. So just in terms of disclosures, I'm actually a video editor for Medscape. I won't be talking about any of those activities. And then I've recently had a book published called Physician Suicide Cases and Commentaries. I'm never quite sure whether that's a conflict or an advert, but anyway, it's available and it's very relevant to this particular discussion. The next slide. So as we have said, we're talking about a medical staff wellbeing committee. And at UC Davis, to be a member of the medical staff, you have to be either a physician, a resident, a fellow, or an attending physician, or a PhD clinician who works within our system. And so we're, as a committee, we're interested in that group of people. Now, there are a whole lot of other people, nurses, social workers, other non-physician faculty, you know, who in reality could probably do with our services. But the fact is that's not our mandate, and we actually work for the hospital side of the health system here rather than the sort of academic side. And so we're looking after literally the hospital and the primary care medical staff, or anyone who's a member of a medical staff. And essentially, we as a group have 4 sets of activities that we do. We'll talk a little bit more about who's on the committee in a few minutes. But we have a process of assessment and monitoring for any of our colleagues who are referred to us because of a concern about their mental health, or potentially a concern about their fitness to practice. We then run quite a number of educational and preventive programs. We have a screening and referral service for people who wish to receive some mental health treatment, but who perhaps were perhaps related to stigma, you know, unable to actually organize the referrals themselves without our assistance. And then we have a number of specific advocacy issues. We've advocated for many things, including taming the EMR, which we know is a big stress on physicians. We've also advocated for childcare and for more gym facilities, and have successfully actually advocated to get a medical staff lounge put into the hospital. So we have essentially these 4 broad ranges of functions, but ultimately the committee is there to ensure patient safety by supporting and helping physicians. So next slide. So let me give you one example of an individual that we've been helping. This was quite a senior faculty member who had a long history of working here, been here for over 15 years, whose chair reached out to us sometime, probably about 6 months or so ago, and who was really concerned about this faculty member because they simply weren't keeping up to date with their charting, with the EMR. They had actually just been asked to stop working at a couple of peripheral clinics that they worked at because essentially their work quality had gone down and they weren't keeping up to date with their patient care. And there was a real concern about some administrative issues. The physician was frequently late for work, seemed to be sort of very harassed a lot of the time, wasn't getting on quite so well with his colleagues. And all of this was leading to a situation where there were quite serious discussions about whether this individual might actually be asked to, you know, take a long break from work or potentially even be required to leave work. So anyway, we obviously contacted the individual who'd been told that he was being referred to the Wellbeing Committee. Maggie and I, in fact, saw him ourselves. We always have 2 people who meet with any physicians who are referred to us. And we spent probably about an hour and a half or so essentially doing what we call a triage psychiatric assessment, which is really just doing taking a very broad view of their general situation, whether they've got any specific psychiatric problems, whether there are any other sort of social or interpersonal issues that they need looking at, and doing a sort of scan type assessment. In this instance, it was clear that the individual, you know, had a significant depressive illness. They had a lot of personal problems in their life with their family, and it was clear that they didn't really appreciate that actually this was really affecting their work in a major way. So we now, obviously, we do this triage assessment. If the individual physicians don't agree with that or don't want to continue on with us, they of course have the option of getting an external independent assessment. But in this instance, and most of our physicians are comfortable running with us, but occasionally they could certainly get an external assessment. In this instance, the physician was comfortable with what we recommended. So, in fact, I contacted a psychiatrist that he'd seen in the past. We got that psychiatrist to review him, change his treatment. We organized for him to have some time off work on sick leave. He was able to get some more therapy going. And in the end, it took about a month off full-time work and then about another month of part-time work, and came back into a slightly different position where we also provided extra coaching for him on using the EMR so that he could manage his records better than he was in the past. And at the end of the day, we've continued to follow him up. And now, about 6 months later, he's working full-time. He's still not back at 100% of his normal activities, but he's certainly working competently and reasonably. And there's no suggestion that he's going to lose his job. And he's respected by his colleagues and has basically been managed completely anonymously and confidentially in a way that has allowed him to be retained and to continue working on his career. And I think had we not intervened, he would likely have ended up losing his job or potentially moving elsewhere and simply not getting the appropriate treatment that he needed. Maggie, do you want to add anything to that case discussion? I mean, you've been intimately involved with him as well.
Yeah, and I think relevant to the topic of this webinar, I think that the message we wanted him to get is that, to get help and support. And I think this is a good example of how the committee was able to reach out to him, get him the support he needed, so he recognized that he could, yes, have a mental health issue, but continue to function well and hold his job. And that's sort of a reminder of the message of our committee, is that don't go underground and reach out, because we can support you in getting the help you need.
And I think just as part of that process, I mean, we talk about the committee here. Actually, the committee is involved, because whenever we assess someone new, we report back to the committee. We meet every month. And so Maggie and I reported back to the committee after our first meeting with this individual. We discuss the individual anonymously in detail with the committee. We actually make it quite clear that we actually, when we discuss the individual with the committee, we tend to sort of change their age or change their department, or make it difficult for members of the committee to recognize who the individual is. And we ask the committee, to have input into, any other potential ideas that they've got, or any sort of extra help that they can provide. And that's a very useful process. So we have, whilst we're seeing him just as a pair, we have the backup and expertise of the full committee to support us. So the next slide, please. So just a little bit of history. California does not have a what's called a sort of diversion program for physicians, or a physician health program. Now, 47 of the 50 states in America do have such programs, and they are specific physician health programs that physicians who are potentially impaired can be referred to, and who can treat them and support them in a way that allows the physicians to continue practicing and maintain their licenses. Now, the Californian program was sunset about 9 years ago now, mainly because it really wasn't doing a good job of monitoring physicians. So what happened then is that all of the the major health systems in California, and we're just one of those, clearly, had to set up their own programs to manage their own potentially impaired physicians. And so that's exactly what we've done. And if you're interested in more detail on this, you can go to the website, which I'll show you in a couple of minutes, for the Medical Staff Wellbeing Committee, and you can actually see all of our policies. You can see, the entire process we use. You can see all the members of the committee, and we also have a lot of resources on that website for individual physicians that they can use, providers in the community who would like to see physicians, other sort of health-related resources of use. So California is unusual in that we don't have this sort of central physician health program, and that any impaired physicians who may need monitoring, and the usual cause of impairment is actually addiction of some form or another, are now managed within health systems. Now that works fine in the health systems, and I think we do a reasonable job, as do the other UCs, all of whom have this similar process going. The difficulty is that at least 50% of physicians in California are in private practice, and are in small groups, and are not covered by physician health programs. So the lack of a central program is a real problem, in that there's a large group of physicians who really don't have anywhere to go if they're having difficulties. At a national level, as I say, most states have physician health programs. If you're interested in those, probably the best two states to look at are actually Colorado and Massachusetts. They both have very detailed websites, and there's also a federation of state health programs that has a very detailed website that can give you more information as to how other states manage the issue of impaired physicians. And move on to the next slide. So what are the impairments that we see and that we focus on, and that lead to physicians being referred to us? Well, clearly one is burnout. We know that physicians, whilst they look after their physical health pretty well and actually live, statistically about 2 years longer than equivalent people in the community, don't manage their mental health very well. And we know that physicians have burnout rates that are twice as high as that for most other professional groups. Disruptive behavior is, again, not that common among physicians, but when you see it, you know what it is. And really that's behavior where you see people who are typically fairly narcissistic, difficult, arrogant characters, who may be very loved by their patients, may be very good clinicians, but who tend to cause chaos among their colleagues and among the system by their sort of entitled behavior. And so that's, that again can cause significant overall problems for patient care. And so we get a number of the disruptive physicians referred to us. Aging physicians is another area of real importance. Within the UC system, there is no requirement to retire at any particular age. And so faculty can continue on to whatever age they wish. Having said that, we know statistically that 5% of people who are beyond the age of 70 have at least some degree of cognitive impairment. And it may be quite minimal, but it may well affect their capacity to, for instance, work as a physician, where they're using higher level cognitive skills. And so it's very controversial as to know what's best to do with physicians as they get older. The majority of older physicians are great physicians, and it's excellent that they continue working and they have tremendous amounts of experience. But unfortunately, there's a group of them that really shouldn't be working, and we need to have some way of weeding out those individuals. There's been a lot of proposals, such as literally sort of almost driver's test assessments, including cognitive screening and medical reviews. Stanford tried to introduce some of those about 4 or 5 years ago, and were promptly sued by a couple of physicians successfully. We're all looking at how best to manage this issue, because we want to include senior physicians, particularly as teachers. But we have to be very aware of the fact that a number of them will be becoming cognitively impaired. Now the areas that most of these committees focus on are the last three areas on this slide. Clearly psychiatric disorders. We've just given a sort of case study of a faculty member with depression. Equally, anxiety disorders and post-traumatic stress disorder are fairly prevalent in physicians. And then, of course, there's the substance use disorders. We could speak for several lectures on substance use disorders alone. But in physicians, the issues really are primarily around narcotics and self-prescribing, and particularly in groups such as emergency medicine physicians and anesthesiologists who have sort of relatively high rates of narcotic abuse. And of course, the other substance that's commonly used by physicians is alcohol. And there's still, in some medical schools, a real culture of abusing alcohol as a sort of reward after the end of exams. So they're the sort of health issues that we look at. The next slide. Now, this is a lecture about stigma, and the reality is there's a huge number of barriers to doctors seeking care. Doctors are actually fairly stigmatizing themselves of mental health. Psychiatrists are typically seen as being crazy by their colleagues, unfortunately, and I have to say I don't agree with that. But there's a tremendous amount of denial about the whole issue of mental health among physicians. A real problem for many doctors is that they don't actually have a regular health care provider, a primary care physician, and they tend to treat themselves or get a colleague to sort of write them some meds or write them some orders. And so, one area we're trying to do is to focus on that and get as many of our physicians as possible actually signed up with a primary care physician. And there's in the past been really a fair number of barriers towards doctors seeking help. Doctors have felt that they're very independent, that they should be able to manage everything, should be able to care for themselves, and seeking help has been really seen as being a sort of weakness. And there hasn't been a real understanding that psychiatric illnesses are just the same as medical illnesses, and they're all disease processes, and we need to get care for all of those. And the result of all of these things has been significant discrimination against doctors who have the types of disorders that I described a minute ago. There's no question that there is discrimination in medical licensing, and the medical boards, not infrequently ask questions about your mental health background, whereas they don't ask questions about your physical background. There are also clearly discriminatory practices in terms of privileging you to work in certain hospitals. Again, people having to perhaps reveal way more than they need to, and as well as for professional advancement. There's no doubt that if you're going up for promotion and you've just recovered from depression, that's likely to stigmatize you. So all of this leads to, again, doctors not wanting to seek care. They'd rather keep it all quiet, keep it all under the carpet. And they're afraid that if they get treatment for, say, a simple depressive illness, that will somehow prevent them getting licensed in the future or prevent them getting the job that they want. And unfortunately, those fears are not unrealistic. And so we have to be very careful about how we work with doctors. And ultimately, we have to change a lot of the culture of medicine and get people to accept the fact that these illnesses are essentially, exactly the same as physical illnesses and need to have the same approach. If I move on to the next slide. So here's a screenshot from our Wellbeing Committee website. You're welcome to look at this. It's on the internet rather than the intranet, so that you can all go through and have a look. There's a lot of information on here, and we're fortunate and very pleased this website's been copied by quite a number of other health systems. So you can see that we have a strong focus on confidentiality. We describe the whole review process we have and how people can get help. We have the members on the committee listed, including their phone numbers, and then a lot of resources, as well as a survey that Dr. Rea is going to talk about in a few minutes. Next slide, please. If I just now focus on this one of our activities, which is the assessment and monitoring of potentially impaired physicians, such as the faculty member with depression. Move on to the next slide. We have a very specific pathway that these individuals go through. We get about 10 to 15 such individuals referred to our committee every year. So that's out of a medical staff at UC Davis of about 1,800 physicians. And so these are all people who somebody, it's usually a colleague or a supervisor, often a training director or a chair, who's been worried about someone and worried that their performance is suffering. We then do an assessment by 2 wellbeing members, which will always include 1 psychiatrist. And there are about 4 psychiatrists on the actual wellbeing committee, which has over 20 members. Most of the people are referred for treatment. We actually don't keep formal records. We do keep a sort of written, handwritten record, which is kept in a locked cabinet, really for our own purposes. But we don't call these sort of formal assessments at all. And our approach is to be very much the good guys. We're the alternative to the punitive administrative system. You know, people don't have to speak to us, of course. So far, we've really only had 1 person in about 8 or 9 years who's refused to come to see us. And I think the fact that, you know, people do come to see us is a reflection on the fact we're very careful about confidentiality. You know, we fortunately haven't had any breaks in that I know of, certainly. Now, about 1 in 5, so that's just 2 or 3 people a year, we decide that we need to actually get a treatment contract with. That can have a whole lot of different requirements. Typically, it'll involve the individual having either a case manager or some sort of workplace monitor. If they have an addiction, they'll be getting random body fluid testing. With people with alcohol problems, we actually now do that just using a sort of breathalyzer that includes a camera. So they literally just blow into the breathalyzer. It takes their photograph and timestamps the photo. So as well as recording the actual alcohol level, or hopefully the lack of alcohol. So that's much easier than sending people off to labs. But if they're on narcotics in the past and we're treating them for that, then they have to have urine tests. And we typically make these contracts last for about 3 years. They're reviewed every 6 months, and there are copies of the contracts or examples of the contracts on our website. And at any one time, we have between 6 and 8 faculty and residents in monitoring. So really just a fairly small number that we monitor. The great majority of the people that we get referred to us, we don't monitor. We don't particularly want to monitor lots of people if we can avoid it. We only monitor those people who we feel are likely to be at significant risk of relapse. The next slide. And then I'm just going to finish off with an example of a disruptive physician, and then I'll hand over to Dr. Rea. This is fairly briefly an individual who was on the point of being fired, who had about 8 complaints against them in the previous 2 or 3 years, whose department for some reason really hadn't taken appropriate action to try and get them to change their behavior, and who were essentially decided that we were really the last gasp before they fired the individual. We saw this person. It was clear that you know, he had what we would call a narcissistic personality disorder, but that he also had quite a number of life stressors that he was not handling well. So with him, we did 2 things. First of all, we were very confrontative. and very clear that this was a bad thing for his long-term career, and that you know, he needed to try and make some changes. So we really did not do what medicine has typically done, which is just to cover over and avoid the issues with these individuals. We were fairly straightforward with him. And then secondly, we referred him for therapy to an experienced therapist who was somewhat older than he was, very deliberately, to try and give him more of a sort of paternal view of the world. And he's now being followed up. We put him on a monitoring program, and this is about a year. We're about a year now into this. He hasn't had any major complaints against him during that time. But he's still on a very much a sort of last gasp contract, and if he gets another complaint, he will likely be fired. But we're trying to see if we can get his behavior to change. So I'm going to hand over to Dr. Rea.
Next slide, thanks. So Peter sort of explained to you a lot of the focus that we have on terms of, you know, finding physicians who are, and we could just remind our residents and fellows who might need treatment, who need monitoring. But, you know, we're very proud also that we look at our committee as more around the areas around prevention. And I think that is very relevant to what we're talking about today in terms of stigma. We obviously have resources on our website, but we try to get out there into our community. And in my role is I sit on the committee, but I also oversee, you know, well-being activities for our medical students, our nursing students, and our residents and our fellows, along with our faculty. So I sort of look at the full spectrum of the sort of educational continuum. So I go out there along with other members of the committee with education in terms of, and also recently a lot of my work has been very specifically around this issue of stigma. We're going to talk about issues about how do we talk to each other about our mental health concerns, as opposed to my turning the other way. If I'm sitting next to you and concerned about your mental health, I turn toward you, and how do I have that conversation? So a lot of the work that I do in terms of education is to address that issue of stigma. You know, we're initiating on the trainee level a lot of issues around bystander training. How do we talk to each other? And then gatekeeper training. How do the attending physicians, the senior physicians, talk to the junior physicians about their concerns? So you're not performing well. I also want to talk to you about perhaps there's mental health issues that are going on, and how can we get you help and care? So that's a lot of the work that we're doing. Doing even, you know, Peter mentioned earlier the issue, like just an example, the trauma issue. I mean, certainly we see that being in a high stress environment like a hospital here can have triggering events in terms of past trauma. So we are out there talking about adverse child events and past trauma and how it impacts how you might be performing. And then the issue about prevention, you know, we're looking at also wellness initiatives, gyms, lounges, childcare. We put out a statement on sexual harassment, in issues around microaggressions. So our umbrella around well-being is broad, and we feel like what impacts our mental health is broad as well. And then for the physicians, certainly, as we all know, that's fine. You can go to the next slide. We're about to get to that. There we go. Thank you. Is the EMR, which Peter mentioned. One other initiative we have, very much related to destigmatizing, is we want to reach people. So we get out there and we advertise what we do. We present on the topics that I mentioned, but we also send out a survey to everyone on the medical staff, including actually our medical students as well. And this is a confidential, anonymous survey that we encourage people to take and to assess their level of stress, depression, and suicidality. It came from the American Foundation for Suicide Prevention. The next slide, please. We then respond to the survey within 24 hours and start a dialogue. Again, reminding you this is anonymous. So we're trying to bring people in, but we don't force them to obviously reveal who they are. Sometimes we end up just dialoguing with them. You can go on to the next slide. And what our goal, though, is to try to bring them in and get them the resources they need. Sometimes we end up referring through dialoguing. Sometimes we bring them in and we actually see them through our academic and staff assistance program, which is our employee assistance program, and we see them in person. Next slide, please. And so as you can see, we've been able to successfully get 70 of our medical staff through the survey and get them referrals for care. So this is a really nice model. It is definitely labor intensive because we absolutely respond and need to respond within 24 hours. As you can see, 44 of the individuals who responded were at high risk. We had current safety concerns. They had past history of suicide attempts and severe symptoms. So it was our job to be sure that they got the help. So we feel, empowered to keep going with this way of reaching our medical staff because we found, we've identified people who were at risk. Next slide, please. So just summarizing, because I'm conscious of the time and we want to be able to answer any questions. So as you saw, sort of in summary, we look at our committee as Peter mentioned. We assess medical staff. We provide resources, referrals. We can monitor people, and then we have a lot of initiatives around education about mental health and preventive measures as well. Our goal going forward is, and we have started this, is to really engage our senior leadership to think about how we can make provide a resiliency, sort of an initiative for our health center. And this goes across the spectrum of both, obviously, our committee, the medical staff, meaning our licensed attending physicians, but we really value that we're looking at the full continuum, our medical students, our residents and fellows. Because as Peter mentioned, we have to look at all elements if we're going to, make our little stab at changing the medical culture. One of the initiatives that going forward is that in order to do this, we can't just do it from our committee. We're right now trying to engage it at the individual level, meaning the department level. So it's great if I were to come in or Peter to come in and do a presentation on, depression or burnout or suicide, which is wonderful, but there's a lot of power when it comes from within a department. So having champions within a department who bring this forward. So it's someone who is, someone in a particular department, whether it's a surgeon, let's say, who does a presentation on burnout in surgery or does a presentation on about mental health stigma. That's going to carry a lot of valence for the individuals in that department. And then we're going to continue to do how can we impact the actual learning, the environment, if you will. We can help the individual, absolutely, in terms of taking care of themselves, but we also have to have our voice about how we can impact the environment, because that's certainly a huge predictor of burnout and mental health issues. Things like EMR, issues around team-based communication, and then obviously issues around flexibility in work hours, work-life integration. And then using rewards. I mean, one of the, movements which is going along around the country is that when we're looking at particular departments and how they're functioning, we look at, are they making money, of course? Are their patients satisfied? Is there medical error? But now the next step is how well are their providers? So when we start looking at that as a quality indicator, we know we're really beginning to move the dial a bit in terms of the mental health of our providers. I think that's our last slide. So I think we're good. We have saved a little bit of time for questions. Maura, I think you're manning the questions, so let us know how you want us to do that. Or do we have any questions?
Sorry, we do. We have two questions.
Okay.
Someone asked asked why does the whole well-being team meet with the doctor to do triage? They were wondering if that might seem overwhelming for the doctor, but you did mention in one of your previous slides that everyone seems to come quite willingly, but they were wondering about that initial reticence.
Yeah, actually, that's a great question. Let's clarify. The whole committee does not. Whoever asked the question, that would be a bit overwhelming and feels sort of like we're bringing you in front of the panel. Absolutely not. Two of us meet with the individuals just so we have at least 2 ears and eyes on the situation. And then after that, we bring back the case to the committee anonymously to review what we saw, what would happen, and then what is our plan going forward. Again, to get any input, get ideas, maybe another set of ears in the room. But only 2 people meet with the individuals who are brought to the committee.
And I think that it's worth commenting on the fact, why do we have 2 people? I mean, we used to, for the first 2 or 3 years, just have 1-person meeting. And I think we soon realized that that was just medico-legally fairly risky because you get into a sort of he said, she said situation. And so we deliberately now meet with 2 committee members at all times so that, the committee members can sort of, confirm what's discussed. And we think that that's a much fairer process. It also allows us to try and also make sure we have a committee member who's the same gender as the individual being assessed, because I think that's very important. And so, we frequently end up with having, a male and female committee member.
Great, thank you. There's another question posed by one of our audience members saying, you mentioned focusing on issues like trauma exposures, ACEs, microaggressions, etc. Do you ever make reference to secondary traumatic stress as a risk factor for PTS responses to raise awareness of the impact of indirect trauma on physicians?
That's an incredibly important point. I think that, when I mentioned that, the idea was that I wanted the audience to know that we are looking broadly at the factors that impact our providers. And the person who asked the question, that is absolutely a question, and an issue that impacts providers, and that those are the kinds of things that we will include in our educational initiatives when we go out and include that as a factor. Have we done any specific interventions on that topic? No. Though actually one of my additional roles is I do not infrequently debriefings, and where I go out to departments where there's been whether a difficult outcome or a traumatic outcome with a patient, and that topic certainly comes up. But it's a great point. That's something that we need to include.
Well, I think on the same issue, I mean, our current chief of staff is actually very interested in the Candor program that some of you may well have heard about. This is a sort of program that's been validated through AHRQ in about 14 sites around the country, and essentially sets up a process where after any sort of major incident or unexpected poor patient outcome, there is a process whereby the sort of secondary victims of that situation, be they the physician or the nurses or any other staff involved with the patient, as well as obviously the patient and their family, are contacted in short order by members of the Candor team, who are knowledgeable and who coach particularly the providers as to how best to interact with the patients. Say there's been a surgical disaster, and I mean, we want our surgeons to be as honest and straightforward with their patients about that as possible, and if necessary to apologize and to be very clear as to what happened, both so that the individuals who've been traumatized through the event are assisted, but also there's some evidence that actually that has a long-term medical legal impact, and manages to potentially reduce the number of suits that are sent forward.
Wonderful, thank you. We have a couple more questions. This one is a sort of a two-part question. One, is the committee compensated for their time? And in addition, have you considered having respected staff or department chairs discuss their own mental illness? And this individual says, I believe this would do much to address stigma.
So I think that's an important, interesting question. As the chair of a committee, I get compensated for up to 10% of my time to work in this area. I spend actually significantly more than 10% of my time on it. Dr. Rea is the member of a committee who does the most, with me on this, and she's also compensated as part of her normal job to look after and to develop these programs. But the other committee members are not compensated. And they in reality spend less time, but quite a number of them actually do a lot of activities in their departments and with their local groups, even although they're uncompensated. A couple of committee members actually have had their own department start compensating them as the sort of the sort of physician most involved in well-being in their department. And we have been certainly arguing very strongly that we should be having sort of more sort of compensated parts of time for physicians across, and obviously other staff across our system to work on this area. And I think that'll come. I think we're going in the right direction now. What was the other question?
Oh yeah, the other question was about having individual physicians talk about their personal struggles. That's absolutely, I agree. Whoever asked that question, it's very powerful. We've done a few. We did one of actually about a year and a half ago where we had physicians talking about their struggles. We labeled it, how have you been able to stay resilient, and encouraged physicians to talk about their struggles. But I agree that's something we probably could do more of. In my other role, I'm doing that on the student level and the trainee level, because I think if they can see their senior people talking about that, that would be probably more powerful than any workshop I would ever give about destigmatizing mental illness. So we have one planned for January on that topic, and actually our medical students themselves have put together a project where they have their own panel where they're sharing their stories with the goal of encouraging their fellow students to reach out for support.
And just to add a couple of comments, I mean, we also have a member of the committee who is very open about the fact that he's had a long-standing alcohol problem. He's been sober for literally 25 years plus. And has done very well and is very committed to assisting any other physicians with alcohol problems. And we've also been fortunate in that a couple of the people we've helped over the years who are now doing great and back at their jobs and fully functioning, they volunteered to actually talk to people who are being referred to us to just reassure them that actually the process works. And that things will be okay. And so it's very helpful now that we've been doing this for so long. We've got almost a group of graduates around that we can go to who can actually speak to people who are being newly referred, and that's very powerful.
Mm-hmm.
Great. And we have one final question. We have 3 minutes left. I have a brief outro. I'm wondering if you could potentially just address this briefly. But we have someone who says that they are bear with me, sorry, I just lost the question. I train physicians in the EMR, which is electronic medical records at the Department of Medicine, and I wonder what can be done to encourage physicians to speak out about their challenges when they're expected to always be the ones who take care of others in general.
I mean, that is a huge challenge. I mean, physicians tend to be very proud. We're trained to deny our own personal needs and always put patients first. And that's, if you look at the Hippocratic Oath, all versions of it, it always says that. And I think that's right. I don't have a problem with that. But I think we haven't put ourselves up enough. I mean, one of the things that I think is very encouraging is that the increasing number of institutions that are actually accepting the Institute for Health Improvement's recommendations on adopting what's called the quadruple aim. We all know about the triple aim of sort of better care, better health, and lower cost. But the quadruple aim includes clinician wellness as being a core aim of health systems. And I think, that's something that we're keen to, to adopt here. I hope that happens across the whole UC system. And I think that really provides a major leadership focus for reducing the stigma in this area. If you actually say, hey, clinician wellness is something we've got to work on, and it's one of our 4 major aims for the entire health system.
Wonderful. Thank you so much. I just have a brief outro. Thank you, everyone, of course, for joining us on this interesting topic and for your willingness to learn. I wanted to just remind everyone that as faculty and staff, you have individual behavioral health benefits. If you go to UCNet and simply type in the keyword behavioral health, you'll find information about your individual behavioral health benefits through your medical plan. In addition, you'll also find resource information about our EAP or FSAP, which is a faculty staff assistance program. And most UC locations have on-site employee assistance offices with counselors that you could speak with face-to-face. In addition, a list of all EAP resources is available on UCNet by simply typing in the keyword EAP. And again, just want to remind everybody that the recording link will be available on Monday on the Stigma-Free UC page on UCNet, which is part of our system-wide well-being part of UCNet. And please, of course, share this link broadly with your colleagues, friends, and family. And look for our announcement about the next webinar in December on the Stigma-Free UC page on UCNet. And of course, a big thank you very much to our presenters for their expertise and for sharing their time, valuable information with us. Thank you both.
Thank you.
And thank you.
Okay, we're going to wrap it up.